Okay, so like Mark says, we've got about 30 minutes now, and what I wanted to do was try and get across to you some ECGs where the changes are really subtle and the changes you can look for before those ST segments get big, because there are quite a few things that we can look at in the ECG that can really help us. Like Mark said earlier on, leave the dots on when you do an ECG with someone who's got symptoms, because those changes can happen really, really quickly, but sometimes they happen slowly, and what you don't want to do is get caught out. So I'm just going to share with you a few things that will help you hopefully catch those STEMIs early. Oh, and just a little bit of trivia as well to start with. I don't know if any of you have heard of a chap called Augustus Waller. So this is to do with the first ECG ever recorded. So he was a British physiologist, and back in 1887 he recorded, not on paper, but just like a moving trace of the first ECG. And he used to use his bulldog Jimmy quite a lot. He had a whole load of bulldogs, and he would take this one Jimmy round to the different theatres where there was doctors and demonstrate the ECGs to his colleagues by putting the dog's feet in kind of pots of saline that would help conduct the electricity. So that was the very first ECG. And then there was a chap called Einthoven. You've probably heard of him, Einthoven's triangle. So he did the first sort of electrocardiogram, the first paper recording. And the first chap, Waller, he didn't think that there would be any kind of medical usefulness for ECGs. So Einthoven managed to persuade him that there was. And Einthoven actually got a Nobel Prize for his work with ECGs 2 years after Waller died. So unfortunately, he got all the glory, but he did help Waller a lot. And then finally, this was the first commercially available ECG machine. So this weighed about 270 kilos, took 5 people to operate, and you needed water to cool it down. So if you think the LifePak 15 is heavy, imagine what it was like back then. So yeah, that was again Einthoven who helped put that machine together. So that was in about 1920, first commercially available ECG machine. So yeah, I always like a little bit of trivia. Just to mention the cardiac care information circular, you're probably all aware of this, but this is where all the cardiac pathways are put together into one document. That's available on the Pulse and on the DPG app. I don't know if you all access the app, but I do quite a lot, and it is actually really good. I know it's slow sometimes, but there's so many things to remember now. When I first started with Mark, it was just a STEMI pathway. Well, we didn't even have STEMI then, but there was a STEMI pathway that came a bit later after I joined. And that was easy because it was just one pathway. We had a little card to tell us how many millimeters of ST elevation, and you knew what to do. But now we've got STEMI post-ROSC, left bundle, PACE, Kawasaki disease, high-risk ACS, emergency arrhythmias. We can't expect you to remember all of those pathways and the exact indications and contraindications and where the centres are. So it's all on that document. I know it's long, I know it's a lot of information. It's really hard getting that balance between too much information and not enough, but it is out there just in case you're not aware. I won't go through this because I think Chris explained well, didn't he, about this is about stable. Actually, maybe he didn't talk about stable and unstable angina so much, but stable is where you've got your coronary plaque. It's a very narrow lumen, but your heart knows what it can do. You go up some stairs, you exert yourself, you might get some pain, you take your GTN and it goes away. There's no clots there, and your ECG should be normal. But when you actually, so these, like Chris said, these plaques become hot and can rupture, highly thrombogenic, the clots form, and then you either get ST depression or ST elevation. So you've got your stable and then your unstable, and your unstable can be your angina, your STEMI and your non-STEMI. And like Chris said, these do just as badly in the long term as your STEMIs. And we didn't really used to treat them that seriously. I'm going to skip through this one just in case of time. So what I'm going to show you now are a series of case studies. I think there's about 7 or 8, and they are all real case studies from the LAS. Some of them are tweaked slightly just so that they can't be recognised. But they're all real cases and real ECGs. So some of the ECGs might be a little bit grainy. You might not be able to see the graph paper quite behind them that well, but they're all real ECGs. So the first one, this was a 48-year-old male. It was given as chest pain. When they got there, he said there was some tightness on the right-hand side of his chest when he was brushing his teeth. He had a history of bypass and was on cardiac medications. He had a heart rate of 38 to 50. So even really if you are on cardiac medication such as beta blockers, 38 is quite a slow heart rate. So whenever you go to somebody who's suffering some kind of what you think might be cardiac symptoms and the heart rate's quite low, especially if they're not on beta blockers, there's something going on there, because normally people would be a bit stressed if they think they're having a heart attack and they're calling 999 and the heart rate would be up a bit. His BP was 102/58, BM 4.4. He was clammy, but he wasn't pale, and his pain was only 3 out of 10. So symptoms, they're not really that convincing. And that was his first ECG. So don't worry about the graph paper. What I've learned, and I think one of the other doctors talked about it earlier, is the more ECGs I look at, the more I know it's about pattern recognition. So sometimes you can tell by looking without even looking to see how many millimetres of ST elevation, measuring it on the graph paper. If you look at patterns, you can start to figure out what's going on. So can anyone see anything on there, given that history that we've got about the patient, anything that just makes you slightly suspicious that things might start to change? Flip T, someone said, whereabouts? In where?
V1, V.
Oh, so you're allowed to have a flip T in V1, and if you've got one in V1, possibly it's okay to have it in V2, but not always. So you probably should be a bit more concerned about V2, yes. Anything else?
Just the shape of it.
The shape of it, yes, like you say.
5 and 6, just so much if you come sort of this way.
That one, yeah, just that shape. The more you look at them, that just looks a little bit suspicious. Yeah. And was someone going to say something over there? What, down here? And what is it about AVF? Just looks, yeah. So I think what you're referring to, and this is really well spotted, it's the angle, the shape of the upstroke of the T wave. So normally it would go along and then up. That's what you would normally expect to see. But when you start to get ischemic changes, it will start to come up from the QRS diagonally straight up. So it doesn't go along and up, which is still doing a little bit here, but it's starting to go straight up. And as what you'll see more later, you'll see they go straight up like that. So that's one very subtle thing to look for. So well spotted. Any other subtle changes? There's one key one here that kind of relates to what we're seeing. Where's the arrow gone? Okay, it's not doing an arrow. Which relates to what we're seeing in AVF. And probably 3. Q wave in 3, did you say? Yeah, it's difficult to see from the back, I think, and because it's poor quality, there's a little R wave first, I think. So that probably makes that an S wave. So what I'm getting at is this little bit here that is really subtle. But have any of you ever heard of one of the first things to change with an inferior STEMI is an inverted T wave in AVL? So if you've got nothing else and you go to somebody who's got some kind of cardiac symptoms, particularly like indigestion or burning type pain, we seem to see that a lot with inferior STEMIs. So if you've got the atypical presentation and it's not a convincing history, it's so easy to miss things. You might just do one ECG and take the dots off. Better to leave them on. But if you've got, that's the first thing to go when you start to occlude your right coronary artery. So normally when you've got inferior ST elevation, the pens have gone. Normally when you've got inferior ST elevation, the right coronary artery is the first one to block. So if you think of the coronary artery anatomy as a ring and a loop, so this is your right coronary artery, left anterior descending and circumflex. So 70% of the population, the right coronary artery feeds the AV and the SA node, and we'll talk about that in a bit, but that's the artery that's likely to be blocked. And so when your right coronary artery is blocked, this is the pattern that you will start to see. So inverted T wave is the very first thing, usually, most of the time, the change that you will see before you get your inferior STEMI. And then the next ECG belongs to the same patient, and that's just a little bit further down the line, and you can see they're kind of thinking, where's the isoelectric line? Is this ST elevation? But you have got, sorry, I'm not sure why this. There we go. So you've got your T wave inversion, but now it's changed to ST depression as well. So that follows that order: T wave inversion, ST depression in AVL, and then you usually start to see ST elevation in 2 or more of these leads here in the inferior view. So if you didn't know that already, that's just to give you a clue of the early changes that you might start to see, because these are the ones we miss. You know, those big anteriors are easy, and sometimes the inferiors are big, but a lot of the time they're subtle. Remember, we only need 1 millimetre in 2 leads next to each other in the inferior view to be able to go to the cath lab if you've got symptoms. That's not very much at all. And really now, because I see this so much, it's just that pattern. I don't need to measure how many millimetres or worry about the graph paper. Is it up a bit here and is it down a bit there with an inverted T wave? That's almost certainly a right coronary artery occlusion. And you wouldn't be wrong to go to the cath lab, you know, if it was 3/4 of a millimetre, 1/2 a millimetre, but you definitely had that pattern. And then normally there's other things that start to change. So look, you're getting biphasic T wave, or it could even be a U wave, which you sometimes see with ischemic patients. Also, it's a tiny bit of ST depression there. So you will start to see other things change, usually around the ECG as well. Okay, any questions on that? No.
Sorry, what was the time frame between those two?
Let me have a look, if I can see how to make this go back. Oh, there's no time on that one. I think it was only about 10 minutes. It can range from a couple of minutes to over half an hour in some of these ECGs that we tend to see either sent in by crews or, yeah, it's usually fairly quick, but it does vary. Okay, this one, when you read how the call was given as when you're on the way there, you can imagine thinking this probably isn't going to be anything cardiac. Look, 48 again, this is not a good age to be 48 years old. 48-year-old male, given us heartburn and vomiting. So again, one of the messages I want to take away is this heartburn feeling, this indigestion type feeling. We often see patients have had curries, have had chili, and it's so easy to say, oh, the pain's just due to that because they've got this burning feeling, but we need to take it seriously. His address was opposite a South London emergency department, didn't look unwell, he was watching TV when the crew walked in, he looked quite relaxed, but his sister had called because she was worried and he was a bit sweaty earlier. And I think Chris mentioned earlier that someone did, I think it was Chris, that sweating is a bad sign. And I remember hearing one doctor say, you know, if the patient's sweating, that should make you sweat because it's a really ominous sign if someone is really sweaty, unless it's, you know, middle of July like it has been this year and very, very hot. He'd also had episodes of heartburn over the last week, so that's just something that should make you think, you know, that stuttering pattern of when you're getting that pain coming and going. And the only thing was he was a smoker, no medical history. So it would be easy just to think, you know, what's this that we're going to? And that was his first ECG. This one isn't so subtle. I think now we've been looking at that last one. Unfortunately, the first ECG may have just shown T-wave inversion here, but can you all see what we're seeing here in terms of ST depression, T-wave inversion, and then we have got subtle ST elevation around here. And you're starting to get more of that angle, see, that T-wave coming straight up from the QRS, whereas if you look here, straight across and up, that's how it would normally look here, but it's going straight up. And the more you look at STEMIs, that you know are STEMIs afterwards, you'll see that shape with the T-wave. Of course, there's lots of times when you'll see that shape and it's not a STEMI, but it's just one of those things that can help you. And again, you know, you look over here, there's a similar biphasic shape here, and you're getting a bit of ST depression. It's only subtle, but, you know, we need to take ST depression seriously. So, of course, this patient went to the cath lab. I think they did take quite a lot of serial ECGs to be convinced about it, particularly given the patient's history, but it was really well picked up because they did spot that kind of the change in AVL, first of all. Right, that's just showing what we were talking about. And also, see, the machine hasn't picked up yet. It hasn't said confirmed STEMI. But it has given some suggestion. So I think Mark mentioned, you know, use that as a second clinical opinion. Don't ignore on it, don't rely on it, but yeah, don't go on it completely, but don't ignore it either. And then I think that was only a few minutes later. Let's have a look. So that was at 1720. At 1722 meets ST elevation criteria. So they picked up on that before the machine. And in some situations, you know, maybe it doesn't make any difference, so what? But there are some situations when it will help you if you can catch these things early, particularly with atypical symptoms. And I do think from all the cases we're seeing that atypical symptoms are becoming really common and almost typical. I don't know if you're seeing a similar thing. particularly things with, you know, right-sided pain, pain worse on inspiration. If you say to somebody, does the pain get worse when you breathe in, they'll probably say yes, and then it's easy for you to get led down the wrong route of it's muscular or it's respiratory, and we see that a lot. It's not a good question to ask, I don't think, really. And you know, if you prod somebody over here, if you prod them hard enough, they'll probably say that hurts as well, and so it's easy to go down that line of, you know, it's not cardiac, so just be very careful asking those questions. And this is the same patient, and now you can see that the STs have resolved, and AVL's back up, but as we know, we're still going to go to a cath lab, because when you see dynamic ECG changes are a huge red flag. So that's probably another message to take away. When you see changes in the ST segments and the T waves going up and down, you think about that slide with the clot in it. There's something happening there. The clot is waxing and waning, coming and going. There's something dodgy going on, and we think probably that a cardiologist needs to have a look inside there and see what's going on. And that was a bit later as well, so they're up again. Hopefully they're in hospital soon. I know it's boring to go on about it, and we're always going on about STEMI bundles. I know you know what it is, but it is important, you know, and if you can't give the aspirin or the GTN or record the pain score or give the analgesia, just make sure you document why on your paperwork. You should be doing as much as you can en route and making a move, because the quicker that you get that patient in, the less likely they are to have long-lasting, you know, effects on their heart. Once that heart muscle dies, it dies, and so that could be the difference between somebody being discharged in a couple of days and their heart being totally fine, or someone having debilitating heart failure for the rest of their life because it's taken a long time to get to them. Maybe we've taken a long time diagnosing it, etc. So yeah, the quicker we get them in, the better for the patient. Plus, they're more likely to go into VF if you're there with them for longer, and it's better that they do that in the hospital and not with you. Okay, number 3, so 68-year-old female, burning chest pain, just eating a hot curry, pain intermittent for 2 days, but she's sweaty, she's pale, she's hypotensive. So even though she's had a curry and she said it's burning, still all those other things should be making you think, you know, there's something dodgy going on here. And also females, they tend to receive treatment in a less aggressive and more delayed fashion, because I think in the ambulance service we know that women have heart disease, but I think further afield people don't always take it seriously. The public don't realise that it's the #1 killer for women, and yeah, they just, and because they present differently as well sometimes, their symptoms. Okay, so first ECG, anything on there? Yeah, good stuff. So we've got ST depression in V2, V3, again it's only subtle, and then AVL, inverted T wave, and ST depression. And then even though you've hardly got ST elevation there, you've got a tiny bit, but it's that shape again of what's happening around here. So the more you look at it, the more you see that pattern. You don't even have to measure it, you just see that pattern. So what you could do if you it doesn't meet criteria here, so I guess you could do your posterior STEMI and see if that shows anything. But if you know that you've got an inferior STEMI here, then obviously you don't need to do a posterior ECG because it's not going to add anything. But again, good practice, we haven't really mentioned it, doing your right-sided ECG for all your inferiors as well. And that's the same patient. So again, look at this angle here coming straight up. And I've hardly ever seen an ECG where AVL isn't down. Occasionally, when it's the circumflex artery that's occluded, you may not see that drop in AVL, and so that might catch you out sometimes, but most of the time, you're going to have a drop in AVL with that ST elevation. Mark, will you give me a 5-minute warning when it's time to stop? Thanks. Okay, case number 4, indigestion and belching. Again, we keep talking about indigestion, but it seems to be coming up really, really commonly, and the belching too. So this was a 50-year-old male, no cardiac history, and he'd had 6 hours of intermittent indigestion, pain and belching. He was clammy, no nausea and vomiting. So let's have a look at his ECG. Anything on that one? AVL again, so yeah, you're getting really good at spotting this now. So there's a bit going on around here, but you can clearly see that your T wave is inverted here, and you've got some ST depression. But I guess you could argue that in AVF, you have got a bit of ST elevation here, probably almost 1 millimetre. It's a bit wavy, but you have got some there and a little bit there. So it's that pattern. You don't even have to worry too much exactly is that 1 millimetre or not. It's that pattern up round here and down round there. But yeah, always look in here first if there's not much else going on. Plus the shape here is a bit suspicious too. and there wasn't another ECG for that patient. They went to the cath lab with that one. This is the right coronary artery here, which completely stops. And then if you look at the next angiogram, the right coronary artery is almost always C-shaped on the angiogram, and you've got good flow through there now. So even though there were such subtle ECG changes, it's amazing how that that coronary artery was actually blocked.
Why are they so subtle?
In the inferior view, I'm not sure why. Do you know why, Mark? In the inferior view, why you only need 1 millimetre? Why it's so subtle? No one's ever asked me that question before.
You often see slight ST elevation in the anterior view as a normal finding.
Yeah.
As a normal.
But in the inferior view, why it can be completely blocked with hardly anything in the inferior, I'm not sure. Good question, though. Maybe I'll ask one of the cardiologists. Okay, so this one was, it was a 55-year-old male. When we got to him, he said he had some aches and pain in his chest. It was just a 5 out of 10 pain score and worse on inspiration. Remember what I said about asking that question, is it worse when you breathe in? Because most of the time they'll say yes and you'll get led down the wrong pathway. Pale, slightly sweaty. He was in bed with his wife, shall we say, renewing their marital bond. And
we normally call that sex joke.
Oh, don't say that word, Mark. Makes me blush. Medical history of high blood pressure and high cholesterol. And this was his ECG. So anything there? Yeah, good. Because sometimes people look at these T waves and don't think too much of them. But when, particularly, if out of all of them, probably V4, look at what we call hyperacute that T wave is. It's more than twice the height of the R wave, and so that's one of the early changes. I'm sure you probably know that you'll see, not just with the anteriors. It could be anywhere in any of the territory, but we do particularly tend to see them around here more. But these hyperacute T waves. So really hyperacute, there's no exact definition of hyperacute, but they tend to get broader than normal T waves. They tend to be symmetrical, and it's not about the height of them, it's about the proportionality. So the height of it compared to the preceding R wave. So if you compare the two, so it's not about how many millimetres high it is, it's about how big it is compared to the R wave in front of it. So anything bigger than the R wave would be deemed hyperacute, but that, looking at that shape, that is just typical of, left anterior descending starting to occlude or occluded in the early stages. They also do that on the way down as well, so when you've had your STEMI, they tend to go hyperacute before they invert. But you can also see ST elevation on here as well, can't you? So up here in V4, you've probably got a couple of millimetres, V2, you've got a couple, you've got some here. So even though the ST elevation side of it isn't massive, those T waves, particularly that V4 shape, try and remember that shape, that, there's something very suspicious going on there. They're about to have their massive STEMI probably. But also look, there's no reciprocal changes around here, there's no ST depression, and you commonly see that with anterior or anterolateral STEMIs, whereas with the inferiors, you always see the drop in AVL. So
lead 3 T waves starting to flip or be
yes, potentially. I don't know whether that'd be normal for that patient or not, because sometimes you are allowed to have an inverted T in lead 3. But yeah, it does look a bit dodgy. And also, like I said before, in ischemic situations, you can get a secondary wave called a U wave, and potentially that could be going on. I'm not sure. Yeah.
You just had what you that little pattern, you wouldn't mistake it for potassium.
So yeah, you do get big peak T waves with potassium, but going back what Mark said about why doing the ECG, how's the patient presenting? Yeah, so I mean it could be that you have someone with high potassium and chest pain, but generally and how this patient presented, chest pain, sweaty, etc. But sometimes it's not clear cut and you have to back a horse, and it's difficult without being right in front of that patient and to know. But generally in this situation, plus the hyperkalemia T waves. They're either really thin and really tall, or in the later stages they'll broaden out, you'll lose your P waves. There's other things you'll look for as well. Okay, so that patient did have an occluded left anterior descending, but he did get more ST elevation afterwards. And that's just zooming in at the top there on that V4, that pattern, just try and remember that pattern, because you don't want to miss something. So a U wave is a secondary secondary wave after the T wave, and you might see it with some kind of electrolyte disturbances, so another little blip after here, but you can also see it in ischemia as well, so it's not uncommon to see it with MI. And sometimes the machine will calculate it incorrectly, the QT interval, because it'll think that the U wave is part of the QT interval. I must be getting near the end in terms of time. That's just another shape, just to show you, like similar to the last one, hyperacute massive, and look at the size of it compared to that R wave. That just looks very suspicious for something that's going to turn into a big anterior STEMI, or has been one. Got time for one more? Last one. Okay, so 55-year-old builder in a van, just had his lunch, left-sided crushing chest pain, 2 days of intermittent pain. So whenever we hear this, we've been seeing it a lot, you know, there's intermittent pain for a couple of days, it should be making you think cardiac. Thought it was indigestion, hasn't seen his GP for years, increased BMI and smoker, slightly clammy. And sorry, it's a bit grainy, but this is a very subtle one. Anything on there? So I'm zooming in on the bits where there were some changes. Anything on there that you're concerned about? What's that, sorry? V2? Yeah, so you've got a little bit of ST elevation there, and also your T waves are bigger than the preceding R waves, so they could be considered hyperacute, even though they're not massive like the last one. Again, we've got that straight up angle of the T wave there. That we
V6 as well.
You mean that shape of it?
Yeah, it doesn't just,
yeah.
It looks like it's not isoelectric.
Yeah, so slightly elevated. Good. Yeah, so the main things are, yeah, tiny bit of ST elevation, starting to go hyperacute T wave, and also that angle there as well of the T wave. And then if we look at the next one, that wasn't far down the line at all. But it just shows how you can pick up on these early changes. So don't take the leads off, like Mark said, you know, leave them on, keep doing repeat ECGs. And these are the ones you need to get in quick, because it's a massive amount of heart muscle that's affected, and there's no Q waves there yet. They've still got good R wave progression, so it could really make a difference getting them in really quickly. So I think I shall leave that there. Thank you.